Let's now discuss the complex mechanisms involved when a person has low effective arterial blood volume and low mean arterial pressures, as is seen in low total body sodium states, also known as hypovolemic states. I provide a figure here outlining the reflexes and actions involved to return blood pressures to normal. Let us now discuss how the body and kidney respond to loss of extracellular sodium from a process like diarrhea. Recall that extracellular sodium reflects total body sodium and can be determined based on clinical presentation and physical exam. A patient with low total body sodium will be hypotensive and tachycardic and decreased urine output. In a patient with extracellular sodium loss, meaning hypovolemia, there is decreased effective arterial blood volume, which we refer to as EABV, as evidenced by decreased mean arterial pressure, MAP. A decreased EABV is sensed by specialized baroreceptors known to be low-pressure sensors located in the cardiac atria, left ventricle, and pulmonary vasculature. Baroreceptor stimulation results in a combination of reflexes acting to increase peripheral vascular resistance, also known as vasoconstriction, and increase sodium reabsorption by the kidney, both aimed to improve effective arterial blood volume and increased cardiac output. These reflexes include 1. Sympathetic nervous system, and 2. The renin-angiotensin-aldosterone system. Let's first discuss the sympathetic nervous system, also known as the SNS. The increase in sympathetic tone results in the following. 1. Systemic vasoconstriction, which also includes the afferent arteriole. 2. Upregulates sodium reabsorption in the proximal convoluted tubule. And 3. Directly stimulates the release of renin. We just learned of one of the mechanisms by which renin is upregulated directly by sympathetic nervous system activation. There are two other mechanisms that stimulate renin release, both occurring at the juxtaglomerular apparatus. The first is mediated by reduced perfusion pressures sensed by afferent arterial mechanoreceptors, inducing a conformational change resulting in the release of renin granules from the cells. The second is mediated by a resultant decrease in sodium chloride delivery to the macula densa. The mechanisms by which decreased sodium chloride delivery to the distal tubule occurs in low effective arterial blood volume includes three main mechanisms. 1. Decreased renal artery perfusion pressures, thereby altering sodium permeability characteristics at the proximal convoluted tubule. 2. Angiotensin II stimulates sodium reabsorption throughout the nephron, including direct stimulation in the proximal convoluted tubule at the NH3, which is also known as the sodium-hydrogen exchange antiporter. Finally, the sympathetic nervous system directly stimulates proximal sodium reabsorption. Ultimately, the goal of sodium reabsorption is to improve extracellular volume and return blood pressure towards normal values. Upregulated proximal sodium and chloride reabsorption has a cumulative end of decreased sodium and chloride in the lumen, which upon reaching the distal thick ascending limb of the loop of Henle, is sensed by specialized sodium chloride sensing cells in the macula densa, which signals granular cells within the juxtaglomerular apparatus to release renin. The renin-angiotensin-aldosterone system is initiated by the release of renin. Renin, by way of several protein cleavages, results in elevated angiotensin II levels. Angiotensin II results in several actions that serve to increase blood pressure, which includes the following. Potent systemic peripheral vasoconstriction, efferent and afferent vasoconstriction with a preference for efferent vasoconstriction, As we already mentioned, it also stimulates the sodium reabsorption through the AT1 receptor throughout the nephron. This includes direct stimulation in the proximal convoluted tubule at the NHE3 sodium-hydrogen exchange antiporter. Stimulation of the adrenal gland to release aldosterone, a mineralocorticoid hormone stimulating sodium reabsorption from the cortical collecting duct, signals the hypothalamus to stimulate antidiuretic hormone ADH release from the pituitary, thereby stimulating water reabsorption. ADH is also known as arginine vasopressin, which also causes systemic vasoconstriction. The net result is increased sodium reabsorption by the kidney and peripheral systemic vasoconstriction, aimed to return blood pressure to normal. Once this has occurred, stimuli for systemic vasoconstriction and salt and water retention goes away. There are 3 scenarios in which a patient may present with edema and high total body sodium, yet still have low effective arterial blood volumes. These disease states include 1. Decompensated heart failure, 2. Decompensated liver failure, and 3. Nephrotic syndrome. The mechanisms by which these occur will be discussed in future modules. To summarize, it is a complex coordination of reflexes and actions that maintain our arterial circulatory integrity.